All right, welcome to Community Links podcast. We have our guest today, Steve Clark. I've known Steve for almost 30 years, and he's started as a lowly CFO like I did and worked his way up to the CEO role, and he's got a long history and a lot of story. So we're going to ask him some questions. Thank you for being here today, Steve.
Very welcome, Joe. Looking forward to it.
Good. So I was doing a little bit of research on you, and I found out you were a truck driver earlier in your career, before you started even back to college. Talk a little bit about how you ended up where you are. What prompted you to leave the kind of manual labor and get into accounting? Those are two kind of pretty disparate jobs.
Yeah. Well, yeah, I was a truck driver for quite a few years, and mostly what made me do it is my back. And, and I said, I can't keep doing this kind of work and stay healthy. So I was running my last truck driving job. I was running 3 days a week down to San Francisco and back from Seattle to San Francisco. And we were taking trucks down into the streets of San Francisco, right down to Chinatown, going down the street with like 3 inches to spare on both sides of the truck. And one of my favorite stories is my dad was running with me and turned a corner and wiped out a Mercedes 450 SL parked. So that was kind of an interesting thing to go through. But yeah, it was crazy times. But yeah, loading vegetables up off the ground, and it's just work you just can't do the rest of your life. So I decided to get out of that and do something different. And while I did that the whole time I was going to college for 6 years. I put myself through a 2-year college and then a 4-year college. And got my degree in accounting and finance, dual major.
All right. Well, how old were you when you finished your degree?
Oh gosh, I'm terrible with ages. Yeah, I don't remember. I'd have to sit down and figure it all out. Okay. But I was older. I think. Let's see, my son was born in '88, so probably finished college in '86, probably, and. I'm 54, born in 54, so now you got to do a little math. So get your calculator out.
All right, good. Older than a typical college.
Older than typical, yeah. I was sitting around with a lot of young kids, yeah.
Yep. And was healthcare an area that you were specifically interested in?
No, not really. I got out of college and put out an application, and Boeing hired me right away. And so I spent a good couple of years at Boeing, just learning to be a CFO and learning finance and not anything to do with accounting at all.
What were you doing at Boeing?
Oh, it was just a finance director. I don't even know, wasn't the title. Pretty much just calculating change orders on the internal IUS system for Boeing at the time. So the IUS system is a piece of equipment that gets ejected out of the space shuttle and goes out and helps take satellites over and puts them in place and releases them, and then falls back to Earth and gets all burned up. It had gold foil around it, which was really cool, just like aluminum foil, only made out of gold. And so yeah, it was pretty cool. I got my secret clearance and went through that, but that really wasn't my love, and you didn't have a whole lot to do there. So a friend of mine by the name of Johnny DeAnda said, we got this opening in healthcare through Health Haven Corporation, long-term care, and I thought, healthcare is always going to be along. Doesn't matter how bad the economy gets, you're always going to need healthcare. So I jumped over then, and I've been there ever since.
And you were in Seattle at the time?
Actually, Tacoma.
Okay. Mm-hmm. So then that was long-term care?
Long-term care with Hill Haven Corporation, and stayed there for quite a bit of time and did some traveling for them out to just nursing homes, because that's what they had, nursing homes. And then got a chance to move down to Chehalis as my first finance director position for Assured Home Health in Chehalis. And was there for 3 or 4 years. Got fired the first time in my life there. That was kind of exciting. And
what happened there?
It was one of those situations where the organization found itself in trouble, and I feel like, I was kind of the person that helped them grow in the area they need to grow. And then the bottom line is that didn't work out. And so I don't think I really did anything wrong, but they kind of needed somebody to blame. And so I took the blame, and they let me go. So that was kind of a low point in my life. But through that, I started, my son was just a baby, and I raised him for the first year as I was looking for a job, and ended up in my first role as an FQHC for Leah Lane over in Othello as a comptroller.
Oh, yeah.
So another couple of part-time jobs in there, but ended up, that's where I kind of landed into the FQHC world, was from that firing to ended up going to Othello for Leah Lane.
All right. And you moved from Tacoma to Othello then?
Yeah. Yeah. Well, actually, at the time I was in Chehalis. We moved from Chehalis to Othello. Yeah.
Yeah. Good. So when you started at Columbia Basin, did you feel like you really had an understanding of what it was to serve the low-income uninsured people?
No, I didn't. And got into it, didn't really know what I was doing, in a sense. I knew accounting, and I knew how to create a financial statement, and kind of led that. And actually, Leah was a good mentor in that regard, and so she was accepting of my learning, and moved us through. And I'll never forget, though, one time we were in this. I just lost it, so I lost the story, so I'm going to have to come back to that one.
Okay,
yeah.
So when you started, you were their CFO?
No, comptroller.
Oh, the comptroller.
Yeah, Leah Lane was both the CFO and the CEO.
How big? Do you remember how big their budget was at that time?
No, I don't. Yeah, I mean, we were.
How many sites did you have?
Just one site, and probably 7 or 8 docks, and dental as well, and a pharmacy. So
you had a pharmacy.
I think we had a pharmacy.
Oh, you did. You were actually, as I recall, you were the pharmacy supplier for the other community health centers in Central Washington.
Okay.
You were buying 340B and you were selling it to the other community health centers.
Huh. Leah was making some money on it.
She was probably making some money on that. But when you how long was it after you started before you became the CFO?
I was never a CFO for Leah Lane.
Oh, you weren't?
No, for Columbia Basin Health. I actually moved moved over to Wenatchee to be the CFO in Wenatchee from Othello. And so that was my first title as the chief finance officer.
Mm-hmm. When you were at Othello, did you have compliance requirements as well? You look at the industry and it's like you've got financials, you've got the revenue cycle, and you've got compliance, all the federal and state compliance. Were you responsible for all of that as a controller, or was that Leah Lane?
No,
and you
that
just
was
did financials.
That Leah Lane. I think she took care of all of that end of the business, and we were so small. I mean, everybody was so much smaller back then. All those compliance words, and it just really wasn't discussed. Right now, I can't even remember. I mean, that was like a lot of years ago. I can't remember for sure. If billing reported to me as the comptroller, it did when I moved to Wenatchee, and all of a sudden as a true CFO, and sat on the management team. And that was really my first gig where I felt like I was in upper management. In Othello, I just worked for Leah Lane, but when we moved to Wenatchee, I was a part of the management team, and that was a big difference. It was. I really enjoyed it. I really felt at that time that I'd found my calling, and I wanted to eventually be the Leah Lane. I wanted to eventually be the boss. And so I started working towards that in Wenatchee.
Oh, good.
Mm-hmm.
So did you feel when you went to Wenatchee that the leadership of the two organizations was very different?
Oh, yeah, it was hugely different. Yeah. Yeah, Ben Flores was the executive director at Wenatchee, and he ran it with a management team. So we had the medical director, myself as a finance director. We had an HR director, and we were the team that Ben talked to. And I don't know that it was as formal as I had it when I was the CEO, but at the same time, it was a way of getting information, out. And there's a gentleman there by the name of Malcolm Butler, who was the medical director, and him and I designed a pay for performance model, one of the first times that FQHCs have ever used one. And and eventually went on the road with it and shared it with other FQHCs and stuff like that. And that was a really good time in my life where we were building a really good, strong. When I got there, the first thing I did was do an analysis of whether the business was going to make it, and found out it really wasn't. We had a lot of AP and no cash, and so I kind of took that information. And one of the things that I've always been really able to do is communicate the financial world to people that aren't interested in it. And if you really talk about doctors, many doctors aren't interested in the financial world. So, but I was able to take that information and go into Malcolm and Ben and say, if we don't do something, we're going to shut down because we're going to be out of cash. And it was like, whoa, how come we didn't know this? Well, the guy that was there before me, he knew it, but he just couldn't communicate it so anybody could listen. And so for some reason, I was able to connect with Malcolm and Ben and show them how we need to do something, and we need to do it right away. So we found things like we had a small, it was actually we'd converted some of the bathrooms into exam rooms. I mean, we were so crowded into this little building, and
if you didn't like if you didn't like their diagnosis, you just flush them.
Yeah, that would work. Yeah. But so we were open on Saturdays, and so what the staff would do is they would basically say, well, we're going to pay. The rule was we're going to pay you for 8 hours on Saturday, whether you work it or not. And so, the last patient was scheduled for 4, but if nobody showed up after noon, they would just shut it down. They would just close the doors and walk away, and they get paid for 8. And we were only seeing, like 15 patients for, 2 doctors for an all day thing. And it was like, this is the exact thing that we need to stop because we're throwing money away. And so, we really looked at that. We did some incentives things, that were really exciting. We came up with this idea. We're going to pay $1 extra for every patient that an MA put in a room over 15, because we're trying to get to 25 patients a day per provider. And we really came to realize that the patients were going into the rooms with the MA. So the MA wasn't willing to put a patient in the room, then productivity couldn't happen. So they were the barrier to good productivity, the MA. So we changed it. We said, okay, for every patient over 15, you're going to get an extra $1 on your payroll. And the way it worked out is we actually had MAs stealing patients from somebody put a patient in a room, and an MA going to take them out and put them in their room. Yeah. So it worked a little bit too well. So that was pretty fun. But yeah, so yeah, we learned a lot about incentives and yeah, it was a good process.
So is that, out of curiosity, when you're looking at those kinds of changes, you have to have buy-in by the leadership or the CEO. Was that hard or difficult? Because sometimes there's a resistance. I've seen a resistance to change, especially if they think it's a negative for either providers or for patients. How did you get the buy-in?
We didn't really have to worry about buy-in with Ben. He was kind of doing his own thing, and it was like, and Malcolm and I just teamed up, and then we had an HR person come in. So an operations person come in, and they really helped too, by the name of Cheryl. And the three of us then were working to get this kind of thing done. We didn't really have to go to Ben and get something bought off him. So he was really a good leader in that sense, is that he saw what we were doing and let us do it. And
Malcolm, as a physician, was supportive of the process too. He bought into that.
He did because he could see that financially, we weren't going to make it. Mm-hmm. And so he planned on spending his career there, I guess, and he bought into it. Now, I'm not going to say that all the providers bought into it, but we started putting out some pretty big production checks, some pretty big incentive checks. We were paying I can't remember now how many dollars for every pregnancy, for every delivery, because providers are really frustrated. They're trying to get sleep, and they have to get up and do call, and they have to go down to the hospital, deliver the baby. And this one lady delivered, like 15 babies in her in 30 days. It's just like twice as many as normal.
Because of the incentive?
No, just because of the bad luck, because of the timing.
Oh, I see.
But she got a check then for a large check because of the way the incentive worked. And she goes, yeah, this is really nice, and it makes me feel a little bit better, but I don't want to do that again.
Yeah.
Yeah, it was just a tough month for her, but at least she got some money for it, and they felt better about it.
Yeah.
Well, we had another guy that worked for us, and he was a great physician. He did a good job. But he saw all these people. He made up at one of the provider meetings. That's kind of one of the differences that I did. I started going to medical provider meetings. As a finance person, I went to the provider meetings and listened to what they were going through and gave them a report and that kind of thing. And I don't think that was done very often in those days. But he was seeing all these incentive plans. And we had this incentive thing going on for probably 6 or 9 months. And we're putting out some pretty big checks. And he stops Malcolm in the hallway afterwards. He goes, why are people getting these checks? I don't understand. and he was a doctor, and he just didn't realize he had, of course, all of the meetings we talked about provider productivity, but he just didn't register in any of the times that we had this big program going on. And it'd been going on for 9 months. So yeah, pretty amazing.
Interesting. Did you create incentives for non-providers? Like nurses?
We did. Yeah, we had incentives for the whole team. Yeah, nurses and MAs. And
that fit together okay?
It did. Yeah, it did. It was pretty basic, but everybody got to share in it a little bit.
So this is a little bit jumping ahead, but did you include incentives after you got to Valley View?
Oh, absolutely. Yeah.
So
used the same plan.
Did you?
Mm-hmm.
No modifications to that plan?
Oh, sure. A lot of modifications over time, but it was pretty much the same plan that I used. Yeah.
From the beginning?
It seemed to work, yeah.
Yeah. Yeah. Good. So when you're dealing with the growth in a community health center, and maybe the growth didn't happen at Wenatchee, did you grow at all when you were at Wenatchee?
We continued to grow. We continued to grow pretty major. One of the things that we did is we bought and remodeled with the help of the hospital and something called off-balance sheet financing, which was a new term back then. So we were able to buy and remodel and turn into a really nice health center. In fact, they're still using it today for building exam rooms and a proper pharmacy and dental and really made it a nice building. And I was able to, as the finance director, kind of manage that whole build. This building's always been something I'd loved. And so I got to do that formally, and that was a pretty exciting time.
How long were you there?
4 years, pretty close to 4 years. Yeah, it was a busy 4 years.
Mm-hmm.
Mm-hmm. So yeah, we were growing. Yeah, absolutely.
Mm-hmm.
Demand.
Yeah. Yep.
So from there, I one of the things I want to do, I always said, I want to be the leader, and I got a chance to take a class through National Association of Community Health, NAC, and it was through Johns Hopkins University, and it was a leadership program designed for FQHCs and leadership. And so you got to go to the NAC conventions and have a class a couple of times, and then a lot of it was online. We did things in that class with the Myers-Briggs, the personality things, and you sent out your peers and your bosses. You sent the survey out to get an understanding of what kind of leader you were, and it gave you some feedback. And that was really mind opening in a sense, is starting to learn more about yourself and how you lead and what you can do better.
What anything in that process that jumps out?
Well, yeah, now I'm an old white guy, but back then I was a white male, tall, not afraid to speak my mind, give my opinion. And so I found out through that I was very unapproachable. People's perception of the finance director at that time, because then I was a finance director, was that that's the person that's going to say no.
Is that the general attitude, or was that specific to you?
I think it's a general attitude that finance people are the people that are going to tell you, no, you can't buy something.
Yeah.
In fact, one of the things that I did right away when I went to work with Wenatchee is a thing came across my desk that I was going to approve purchasing IUDs. It's like, why am I approving an IUD? Well, we can't. Those are $600. We can't buy them unless you approve it. And I said, yes, you can. You don't need to approve to me. I don't need to approve to buy a medical supply that somebody needs. I mean, that's not what we need approval on. Just buy them. And so I looked at it differently as like, we're here to provide services. And we want to be fiscally responsible, but we shouldn't be holding people up from getting an IUD so they have a baby that they didn't want, so that's going to put a lot more cost into the society. So I was always looking at ways to make things efficient and cost effective, but not keep the care away from our patients.
Yeah. So back to your NAC certification.
Oh
yeah. How did what you learned affect your management style?
It made me more aware of my management style. And so I tried really hard to be more approachable, to smile a little bit more often, to change that attitude. And so, I tried real hard, and then 6, 8, 9 months later, we redid the test, the Myers-Briggs thing to see, and I didn't have any effect.
Didn't change anything?
Didn't change anything. I was still unapproachable.
Oh, yeah.
Right. And I don't know that I gave up. I didn't give up, but at the same time, it was like I made a focused effort of being more approachable. But for whatever reason, it didn't really change that the way the people that I tested perceived me. And of course, it wasn't the same people at that time, probably. Yeah. So I graduated and got my certificate of leadership with Myers-Briggs. I mean, through the Myers-Briggs. No, I'm sorry, through the Johns Hopkins University, which was the NAC.
Certification.
Certification.
Mm-hmm. Which included the Myers-Briggs.
Yeah, which included Myers-Briggs. Yeah.
Do you remember, out of curiosity, what your Myers-Briggs numbers are?
Oh gosh, no.
No. So how long was it then? Why did you leave? And because from there you went to Leavenworth.
I was really frustrated because when Ben left, they wouldn't let me apply for the CEO position because I only had a master's degree. I mean, I did not have a master's degree, and so they let the operations manager Cheryl apply.
Yeah. Why did they require a master's degree?
That's just something they felt that you should have to be an executive director of a community health center.
Was that a specific to Wenatchee, or was that
board? That was a board decision of the Wenatchee board at the time, of the FQHCs at Wenatchee.
And there has been time over the years some expectation at the federal level that individual has a master's degree, so it's possibly driven out of that process.
I've never heard that before.
Yep, they've in the past. That's not a mandate, but it's been a recommendation.
Mm-hmm.
And I was just going to ask if you knew about that, what your opinion of that particular policy is.
I think it's a good suggestion, but I think you need to take into account the overall experience of the individual. So when I became the FQHC leader, the executive director years later, I still didn't have a master's, but I had a Johns Hopkins University executive certificate for leadership. Had a dual major in finance and accounting, and when I took my position, it was opening a community health center. So to me, it was a good fit, and obviously I was successful. I guess we'll get into that story later, but. But having a master's preferred kind of idea is probably a good idea. But I think that the executive directors that I see struggle is that maybe you should have some type of business, some kind of financial background, because in a lot of times the FQHCs are getting in trouble because of financial. They don't know what's going on financially, and they dig themselves in a hole and can't get out. Mm-hmm. So mm-hmm. I'd almost argue that maybe we should have a financial certificate required to become an executive director. Mm-hmm. But it might be a little prejudiced because I'm a finance major too. So, and so are you.
That's yeah.
We might not be the best judges of that.
Maybe not, but businesses are made of multiple systems.
Yeah,
and when you're a CEO, you have to understand the systems and manage each of those systems. So if you're a CEO who understands clinical quality, understands maybe specifically medical, dental, behavioral health, but not the financial system, which is a major system in a agency that has to maintain financial viability, serving the uninsured population, then that seems like it's not an unrealistic expectation that individual understands how to read a financial statement.
Yeah, I think my board at Valley View, they were looking for somebody with a business background.
At Valley View.
Yeah.
We'll get to Valley View in a minute.
Yeah.
Tell us about Leavenworth.
So Leavenworth, yeah, because I wasn't applying, I started looking, and I was hired to be the CFO. It was actually a deputy director position at deputy administrator position at a local access hospital, and that local access hospital had a small health center alongside of it, and I really enjoyed my work there. Again, I wanted to step up and to be the leader, and I wasn't going to just go across the aisle from Wenatchee to Leavenworth without it being a raise. And Doug Williams, the administrator of the hospital at the time, he says, "Yeah, I really want to come aboard." And I said, "Well, if you want me to come over there, I'm going to have a title that says that I'm more than just a CFO, because people aren't looking at me." They look at me and say, "Oh, he's just a CFO." I need something that says that I'm better than that in my title. And so that he was able to do that. And I think that helped me further on. I was there for a couple of years and was ready to make the move and started looking around. And Doug did not feel that he wanted to name me as his next person in line. And so I said, if you can't at least guarantee me a shot at it, I know I can't go there, but if I can't at least have a shot at it, then I'm going to start looking. And he understood. So he supported me in starting to look around and try and find my next jump, which was to be the leader of an organization.
Mm-hmm. So the mission of a community health center is to provide access to care for those people who otherwise don't, or either uninsured or underinsured?
Correct.
So when you went from Wenatchee to Leavenworth, did you find a cultural difference? Because Wenatchee was an FQHC community health center. Leavenworth is a hospital with a rural health clinic. They're very, different, maybe perhaps not, but it's been a curiosity for me that the FQHC community health center environment's really focused on providing access to care for those who otherwise are uninsured or underinsured. So it's really focused very much so, as well as federal dollars are for the purposes of supporting the uninsured. You went to you'd been in community health for a couple of agencies. Then you went into a rural health center, critical access hospital. Did you find there was a cultural difference between the two?
No, not really. Again, what my job was there was look at the organization and figured out that financially they weren't doing that well. And so my focus was then, how can we build this? What can we do? Everything in hospitals on bed days. And so the focus was, how can we get the bed days up? We ended up doing some kind of now I can't remember the terminology that they used for it, but it was almost like a
swing bed or something.
Swing bed, that's what it was called. Good job, Joel. Yeah, swing beds and raised our census from like 0.03 to like 1.5 and all kinds of money started flowing. I didn't have a whole lot of involvement in the rural health side of that. So
you mean the clinic side?
The clinic side. That was taken care of by Doug, and he didn't want me as a part of it. I handled the billing side of it, oversaw it, the billing side of it, and that was the other major problem we had when I started looking into it, is that people were, getting the bills, and instead of actually put them in the system, they put them in the garbage because they didn't have the work to do that way. They get caught up that way. Rather than do it, they just threw it away. It was just ridiculous what you found when you get into some of these areas. But we were able to turn it around, so yeah, that was a good time. But the culture, as far as taking care of people, no, there really wasn't any difference. And I think because it's a rural health center, and those docs are there to take care of folks, and they don't really care about the payment side.
So I wonder if they had a sliding fee scale they offered to the uninsured population.
No, we didn't have a sliding scale. Not that I remember.
So that might have been a deterrent, possibly.
Could be, yeah.
If you've got down the road 25 miles, there's a community health center that slides off the bill versus going to a. The reason I bring that up is just because it's one of those kind of divisions I've heard about over the years. Is your FQHC get federal money, but you're not really any different than us, so you're being almost treated, more financially appropriately than we are. We're competing unfairly against a community health center that doesn't do anything different than we do. But then you talk about that sliding fee access, the requirement to see the uninsured, which kind of brought up the question, was there a cultural difference between this?
Yeah, not that I didn't recognize a cultural difference, but I do know the hospital was a significant part of Medicare. And so it might be that, Leavenworth is a retirement place to go, and maybe there was just more people there that on Medicare side, and that's where the money came from. And of course, hospitals back then also got some kind of payment to help them make up the state. So however much Medicaid they had, they got another big bump from on the Medicaid side. There's a term for that, I don't remember.
Yep. So then from there, you said, okay, I'm not going to be your successor.
Right.
Now I'm going to go out and find another.
And we'll find a place.
Find my perfect job, the CEO job I've always wanted. And so you found the community health center wannabe out in the middle of nowhere that didn't have any employees and hadn't really done much. And you said, "There's the job for me." Is that
pretty much?
Is that pretty much what it was like?
Pretty much. Yeah. Yeah. It was. I went over, interviewed with the board at Valley View, and Valley View Health Center hasn't even opened its doors yet. They were looking for someone to help them start it up. And I interviewed for it, and I said, well, is there any money? And we had really good support. Actually, free rent was going to be paid by Providence Corporation. And so in my interview, this is where that finance piece comes in really good, is in my interview. I remember this, and I said, I don't care. Obviously I want the job, but whoever gets the job, you don't want free rent. And they looked at me as like, why don't you want free rent? I said, well, if you get free rent, it isn't a part of your cost report, and your cost report drives your rate. So if you don't have your rent, you're going to have a low rate. And it was like the light bulb went off for them, and they said, oh. So,
where did you learn that lesson?
I don't know. It might be because I was a CFO, right?
Yeah.
Yeah. So yeah, that was pretty cool. So I got the job, and was employee number one.
Oh, you were?
Yep. Employee number one. And then Providence Corporation actually donated their rural health center that was primarily seeing adults to Valley View. And so I went from 1 to about 10 employees and a couple of part-time mid-level providers, and then started recruiting for a doctor and a medical director. So yeah, opened the doors. My first billing was done off of an Excel spreadsheet, and
medical billing.
Medical billing, everything was done off of Excel. Yeah, with the old what are those forms called that we used for years?
ICFAs.
Yeah, HCFAs, yeah.
HCFA 1500s.
HCFA 1500s, yeah.
Yeah.
So that was pretty cool, and hired people and ended up hiring an HR person that only lasted for about a month. And then I hired a second HR person. She was brand new out of school with an HR emphasis, 4-year college, and I hired her, and she's still there. So that was pretty cool. She's been there for like 17, 18 years now. 18, yeah.
How long were you there?
I was there 15 years. I opened it with the one center that was donated, and I was there 15 years and retired. And we were 13 health centers and I think over 200 people.
Good.
Yeah, it was good growth. It was amazing growth and an amazing team.
What out of curiosity, what was the kind of the financial trick that made your growth possible? Because when you're serving a population of uninsured people and they don't pay their full cost, like your cost is $100 a visit and you're only collecting 20. How do you grow without extra funding? There's some sort of a strategy you must have employed or deployed in order to achieve that.
You give me more credit than I do, I think, there. But the bottom line was, I'm doing, how am I going to make payroll, right? I'm the CFO and I'm the CEO, and we have 12 employees. We're trying to open a full-time dental suite, and I've hired some people, and so we can start seeing dental patients. And I'm like, well, how can I make payroll? And it was October, and we had a big open house planned, and everybody showed up. And at that same day, we got awarded the federal grant. So all of a sudden, we got $650,000. But it was a good bolus of cash that we needed to be able to manage a business and grow. And without that federal grant, we probably wouldn't have made it. So the federal grant really gave us the money to be able to solidify and then start growing from there. And it was all a matter of demand. And we moved from one building, an old hospital building, to buying our own building and remodeling it and all of that kind of stuff. So it was just one step at a time, but no real theory. It really wasn't. The strategic plan said that we want to provide services in where people live, but the strategic plan didn't say grow, and it just happened.
What year was that?
What year? I don't do well with years. So
you don't remember when you started there?
No, you have to back up 18 years from now. So what would that be? 2003, 4?
Yes, 5? 2004 or something.
2005, yeah.
Yeah, so...
I was hired May of 2004.
Yeah. Do you remember if you had a pretty good contract with CHPW? Because one of the points I'm getting at on this is there was no reconciliation on your Medicaid cost report. So when you enrolled a person, you got a PMPM. And if you never saw that person, you just kept getting your PMPM because the state wasn't reconciling the cost report. So you end up with a lot of enrollment and a good contract, like with CHPW. The next thing you know, you've got cash flow that sustains.
Yeah, Valley View, and of course we were the first New Start that anybody had seen in quite a few years in Washington State. And we actually came about and started getting bigger after all of the big checks were being cut. So we actually didn't get huge checks from from CHPW. That we got smaller checks, but we didn't get the big dollars that everybody got when that realization that there was a lot of money being made on CHPW.
Yeah,
we didn't get. We got a little bit of it, but not the huge checks that many of the health centers got. And some of them, that was almost their demise because they actually budgeted those big checks that didn't show up after the state got wise and said, we're paying them too much money to do the work.
Mm-hmm. Yeah. So were you the CEO and the CFO
when we first opened? Yeah, because there wasn't anything else.
Then you hired a CFO as you grew.
Yeah, and that's one of my many life lessons is I hired a CFO. And found out she really couldn't do the job. She came in and said, "Oh, I can do this and I can do that and I can do journal entries and I can do that." But she didn't know how to do the work, and so she didn't last very long. And And that turns out that when I hired her, she was friends of one of my board members. And all of a sudden then I've had this problem where the board member didn't like me because I'd fired her friend. So yeah, that whole idea around FQHCs, which I really believe in, one of the rules is that 51% of the users, 51% of your board member needs to be users of the facilities. And they want to be a reflection of who you're taking care of. And so you don't want bank managers and you can't have doctors and all of those on your board without juggling it around a little bit because of that requirement. And I think it's a good requirement. I think it should be continued. But it does sometimes create people that aren't professional. Mm-hmm. And that's what this in this case was.
Mm-hmm. Yeah, when you're going from a CFO into a CEO in a community health center, the board of directors has one employee, the CEO. So you were in a new role really as it related to the board. How did that work for you?
Yeah, the biggest difference between the two roles is politics. And I really felt, and I don't know where I got this, but I really felt that to be successful, I had to be a good politician with my board. I had to talk to them. I had to keep them informed. And so I told them everything. I kept no secrets from my board. And I think that that's what you should do, is that your board knows everything. They don't want surprises. You shouldn't give them any surprises. So every month I sit down, I'd write a board report and I'd say everything that's going on. If there was anything going on with employee problems and the employees happen to be at the higher level, maybe one of my direct reports, the board knew about it before anything because I wanted them to be aware so that I wasn't trying to fight off the board at the same time as manage employees. So mm-hmm. One of the things I did from the get-go was manage my board, kept them in the know, never keep any secrets from anybody.
Mm-hmm. Good. Did you find on the board that some of the people weren't there really for the right reasons?
I think that a couple of people came on wanting to make changes because they really felt that it could be done better. But that really didn't make much difference because the board. Well, the other thing that happened though that I really believe in is that the first few years of Valley View, the first 2 years of Valley View, we had 2 board meetings. We had the regular board meeting, did our business. But the other board meeting was creating board policies, and that board policy was very clear about whose responsibility it was to run the operations and what the board's responsibility was. Had something called an executive limitations document that gave me as the executive director very clear guidelines of what I cannot fail to do, like have an employee manual, like have proper insurance, like keep the board informed of any policy changes and that kind of thing. So, and stipulated the board approved all policies. We created that document, which I still think is best practice. And that helped us later on in a conflict that we went through at Valley View.
Mm-hmm. Good. Did you have key metrics that you were responsible for as a CEO?
Yeah, I had an incentive plan that was implemented probably after 3 or 4 years of being. I borrowed it from a fellow by the name of Greg Brandenburg that actually was the executive director of Columbia Basin Health, where I left years ago.
After Leland.
He was a finance person that had moved up, but he had a really great way of managing his salary with an incentive plan. And how raises were done based off of the NAC salary scale. And it was just fair to everybody in my mind. And I brought it to the board and said, this is the way another health center does it. And that's what they bought into. So it really eliminated that thing that every year where boards don't want to give their CEO an evaluation. It was all done. I made sure it happened. And it was part of the plan. It was part of the policy.
Do you know, or do you have a sense, is that common practice throughout community health centers?
I don't think so. Yeah. Very few of them I've ever talked to have that policy. I've talked about it, but nobody really wants to jump on board.
That's interesting. Why?
Yeah, I don't know. Yeah, change. I don't know.
Change? Is it being comfortable with finance?
No, it really doesn't. I mean, obviously there's some financial measurements in it. One of the things is you have to make a profit. I mean, that's one of the things I got incentivized on is, did I make a small profit? It wasn't a big profit, but no, I don't know why.
Well, were you the one, out of curiosity, were you the one that introduced it, kind of pushed it, the board jumped on?
No, actually my board was implementing this policy. It's called the Carver model. It's come from a Carver model. There's books on it. And my board was in process of doing that when I started with them. So, and it came from because one of our board members was associated with the college, and the college had a gentleman by the name of Dr. Grubiak who really believed in this model, and he was actually helping us learn it and put it in practice. Mm-hmm. And the college still uses that model, as a matter of fact.
Good. So as you're looking at your time at Valley View, were there any significant events or activities or aha moments for you?
Oh yeah, many.
You had said there was one or two that you wanted to.
Yeah, I'd love to share. So again, growing, we had health centers to the south of us, Winlock, Toledo, and Onalaska, and the provider there, the doctor that owned them, they were rural health centers. The doctor that owned them was put out of business because of overprescribing narcotics. And so they were closed down, and they were up for sale. The buildings themselves, the practice was gone. There was no practice list. There were some charts that had to be monitored. But so being the CFO and the COO at the same time, the CFO and the CEO, executive director, I looked at them financially and said, we can really do well with these and we should buy them. And by looking at it financially, and I took my financial picture to the board, and the board said, yeah, this looks like a great thing. Let's do it. So now I had the authority to do it, and I knew it was the right thing to do financially. And so I bought them. I went to my management team and I told them, and my management team was not really on board with it. They were afraid it was too soon. We were too young. We didn't have the reserves. And all of their concerns went to, were pronounced, and I didn't condemn them for saying them, but I didn't really listen to them because I knew it was the right thing to do. I knew it was the right thing to do. And so we bought them. And it turned out to be the right thing to do. But what happened because of that is that they really, they didn't feel they were being heard, and they wrote a letter and submitted that letter to the board that basically said they didn't have any confidence that I knew what I was doing. And at that time, that really hurt. That was like, you think you have people that you work with, you think they're supportive, and you find out, no, they're not supportive. They all signed this letter that basically told my board that I wasn't doing a very good job. And so a couple of things that I learned from that. I had a friend of mine that I was working with, and because of that, it was just there was a lot of tension in the air. There was a lot of anxiety in the air, both on my part and the part of my management team. And I had a friend of mine, so I started looking for a job, and a friend of mine says, yeah, that's easy. When you don't own the business, you can just leave. And I started thinking, yeah, that's really a cheap shot for me. I mean, things getting tough and I'm just going to walk out of here. So I made up my mind, no, I'm not going to walk out of here. I'm going to learn how I can fix this. And about the same time, I got the chance to go to a NAC convention, and I got to hear a speaker, and the speaker came into the room, and you looked at his credentials, and he had a BS, he had an MS, and then he had an MPH. So these were all titles that were after his name of the different degrees that he had. And he got up in front of the room and he said, well, I'm Ralph Carr, whatever his name was. I don't remember, of course. And he said, you can see that I am well educated. He said, so you see the first initials of BS? He said, everybody knows what BS means, right? And about half the crowd chuckled. And then he said, in MS, well, of course, MS is more of the same, and MPH means more piled higher. And everybody in the room was laughing, and everybody in the room was listening to him. And I was listening to him. And I can't tell you that I've gone to a lot of speakers and listened to them, but never really heard what they had to say. And his whole speech was on managing below the waterline. His whole speech was exactly what I needed to hear. And it really sunk in. And the premise behind it was, you can't manage an organization and just charge forward without your team on board. So your job as a leader is to get your team on board. So I went back to my management team and I said, I got to fix this. And this is how I'm going to fix it. I want you guys all to be involved in every major decision we do. And if you do a thumbs up, we're going to move forward. If you do a thumb sideways, that means that you're okay, but you're not real excited about it. And if you do thumbs down, we're not going to do it. So anything we want to do, if you put your thumbs down, we're not going to move forward. And that made them heard. Now, of course, I had to practice what I preached. I had to actually do that. And I can tell you that for the next probably 10 years, there wasn't one major decision that I made that my management team didn't have thumbs up or sideways on. If we had somebody down, we would talk to them and say, what's it going to take? What do you need? What more information do you have? Do you need more financial information before we make this decision? It's an important decision. And in every case, they would come over and they would say, okay, I got it. Everybody else is ready. I can do it. And once they did that, there wasn't any, remember when I was thumbs down, I should have been thumbs down. We didn't do those. We made really good decisions in every case, and grew and grew and grew. And financially, we did really well. Yeah. So that was probably the one major thing that I give credit to for the success of Valley View is hiring really good people, which I did. I ended up with an amazing team, and then allowing them to have a say in what we were doing, where we're going to go. And can I keep going? Because I have this other great story I want to share.
Go for it. We can always edit it out.
Yeah, you can always edit it out. So it wasn't very long after that. I got a chance to go to talk to this. It was a presentation put on by one of the local forums. And it was a lady that had been homeless. Now, homeless isn't a big problem in Chehalis, in Lewis County, but we have some. And she was doing a presentation. And I've always thought, well, how can a homeless person have a baby when they know they're homeless and they're not going to be able to take care of it? It just doesn't make sense to me why someone would do that. And so I listened to this lady trying to explain to me how that would work and why can't they just see the dollars and cents of it. And basically what she taught me, and I was listening, what she taught me was that you can't teach somebody anything unless you're connected to them. And the only way to connect with people is to have something in common, to be at their level in some way. And that made me think back to that guy that taught me about below the waterline. Being connected, that guy connected with the whole entire audience, and every one of those audiences heard him, and I heard him. If he would have got up there with his master's degree and his master's of public health degree and not connected with me, I wouldn't have heard him. And so that's really another learning for me, is that if you want to be able to communicate a change to someone, you have to figure out how to connect with them. Mm-hmm. And it's actually been a part of my life a lot more than I realized throughout my career, is on the reason I was able to help Wenatchee Valley reverse its situation is because I was able to connect with Malcolm Butler, a doctor, and I was able to explain financially why we needed to do what we needed to do, and he bought that. The guy before had the knowledge, and he knew we were going under, but he didn't connect with Malcolm, and he couldn't share that information because there was no avenue for them to connect and listen to each other. And for whatever reason, I was able to do that with Malcolm. We were both loving flying, and that might have been it, but it was just one of the things that's helped my entire career, is being able to connect with people and communicate pretty complicated financial data that gives you a reason to do or not do something.
So when you heard the homeless lady talk,
Mm-hmm.
did you figure out how to connect with homelessness?
Yes, I understood how. I understood that there's a way that you have to do it. Have I ever been in a situation where I had to do that a lot? At one point in my career, right before I retired, actually, I helped establish a primary care clinic in downtown Olympia for the homeless. And I tried to remember that when I went down there, but I went down there wearing a suit, wearing my tie. And it was like when I walked in the door, it was like I was some kind of alien species. I mean, they either ran away from me or they came over and crowded into my space. And so I was very uncomfortable because I really didn't know how to connect with these people. But the one way I needed to connect is not wear a tie. I needed to be dressed down. There was a doctor that we hired. Actually, she's the reason we did it, because her passion was to help the homeless. And she was just this, pretty little petite woman that could be in these very aggressive, dirty people and felt the compassion to help them. She was amazing. And I wanted to help her, help them. And so I helped her, through that effort, we were able to open a primary care clinic for the homeless. And again, one of my partners was always Providence, and many times, and Providence was there and helping us. So that was pretty cool.
Yeah.
Still open as far as I know.
Good lesson there is the board requires 51% users.
Yeah.
And understanding and even potentially training at the board level around socioeconomic issues. Racial conflicts are big. But when you look at the uninsured sitting on a board of directors where you have bankers, you have attorneys, you have community leaders, do you think they're not intimidated?
Oh, yeah, they absolutely are.
And how do you get past that intimidation?
I don't know that I did a good job of having them at the table. Now, again, it isn't, I didn't look at it as my job to fill the board. If the executive director goes out and puts all of his friends or her friends on the board, that's not a good board. That's just a rubber stamp because they know Steve and they're going to do what Steve says. So a board needs to be people that might be more difficult. And I got a complaint from a board member that said that his partner wasn't treated fairly. And I was talking to him on the phone, and he was very well versed. He was very educated, and he said, I said, let's meet. Let's go down and have coffee. I want to talk to you. And he was gay, and his partner wasn't being taken care of the way he should have been taken care of. And he was right. And I said, you'd make a great board member. And he was a difficult board member. He walked around he thought he was a champion to make sure that people that are gay are taken care of. And it was needed at Valley View. And he opened our eyes to a lot of things. And so he was a difficult board member because he didn't take no for an answer. He wanted people to be taken care of the right way. And he made us a better place. Mm-hmm. And so, but, it would have been a lot easier for me if I wouldn't have done that.
Yeah,
because it wouldn't put the challenges.
Sounds like you had a relatively effective board.
Yes.
Do you feel that board was effective because of their own capabilities and leadership, or do you feel you provided a lot of the leadership that they needed as a board, disparate group of people coming together in this, unpaid volunteer position in a very, very complicated industry with federal compliance requirements. And so often those boards just don't work because either people are at the table for the wrong reasons or there's not the leadership, and the complexity of it creates problems. How much of that is responsibility to the CEO to say, I have everybody in this group. I'm not on the board, but I probably understand what's needed more than most, and their effectiveness is going to be a result of my participation in some level of leadership. Or is that a moot point? There's absolutely no ground for CEOs to actually step into that supportive leadership role in a community health center board.
No, I think you have to do that. I think you absolutely have to help lead the board. So what I would say to all my board members is that you guys are part of Valley View for an hour a month, or maybe 3 hours a month if you're really involved. And I'm Valley View 24/7. So I need to be the expert on the operations of Valley View. So you need to stay out of operations because I'm the expert. I'm going to explain anything you want to know. I'm going to show you any report. I'm going to compare us wherever we can to somebody else doing the same thing. But as far as getting any operations, you need to stay out of that. But I also had to help the board manage, help the board with Robert's rules, because if you just let a board meet and talk forever, you're not going to get people at the table. You're not going to keep them at the table. You can't have a 4-hour meeting in the evening because some people just like to hear themselves talk. So then offline, it's a conversation with the board president that says, effective boards start on time and end on time. Effective boards follow an agenda. And so you train them as much as they'll let you train them for that. And I say, absolutely, that has to be done.
So when you're looking at a job, the role of a CEO, we talked earlier about multiple systems. The CEO needs to understand systems, clinical, quality, finance, HR. Would you include in that then board requirements?
Yeah, I mean, managing a nonprofit board is what you have to do to be effective.
How much time did you spend on that on a monthly basis? If you're 40 hours a week, in your case maybe 20 hours a week, how much of as a percentage, how much of your time was spent on board management and communication? And the reason I
got lost at the 20 hours a week because I was thinking you're worth a lot more money than him, but I actually make more an hour than you do. So in every ways we're sidetracked there. But anyway,
40 hours a week.
I think
on a monthly
depends,
basis,
right? It depends.
How much time did you spend on average dealing with board level work? And the reason I ask is if anybody's listening to this, I think that's one of the areas that you go, how much time do I need to spend on working with the board? I can't just set them aside and say it's
I think
their job.
You have a finance committee that you got to spend some time getting ready for the finance committee, and you have to understand what's in the financial report. And so you're doing that as a part of your normal CEO work, but you're also doing it because it's going to go to the board, and the board's going to have questions, and you want to be prepared to answer the questions. So you've got your executive committee report. Now, some executive committees are very active and actually make decisions, and some executive committees really don't meet on a monthly basis. Mine did not meet. My board didn't want their executive committee running the show. They wanted everything done at the board. And so I didn't really have a lot to get ready in that regard. But I made sure that I had a board report that was filled out, that they got ahead of time, that kind of talked about what's going on, what are the problems, what are we looking for, what are we excited about. So a good board report every month went out before the board meeting.
Good.
And then, at the meeting, I was engaged. I was there. I tried to sit at the one side of the board president. If they let me, I would help them manage the meeting. If they weren't interested in that, and the new people were often interested in that, the people who've been at it a while weren't, but they didn't need it. But I would just reach over and say, we're about 5 after, we should get going. Oh, okay. And they would start going. So I helped them manage the day as well.
Right. Good. So when you look back over your career, community health center career, what are 2 or 3 of your real proud moments, the successes that you...
Oh, the successes. retirement was a success. Can I start there and go back? It was, you don't know how good a job you've done until you retire and you end up with a whole yard full of people telling you did a good job. And so I never really felt like I'd done enough until that day when everybody was so amazed on what we had gotten done. So that's kind of one of the things that hit me. I was really proud of the work that I did with the Washington Association Community Health, and through a process helped come up with a reconciliation for FQHCs for the entire state. And I led that part of our organization, and I feel very proud of what we got done, and then helped define the next APM, the next alternate payment method. And I was proud of that. It sounds like it didn't go anywhere after I left, but I was really proud of that work. Every one of the health centers that we opened was a viable. I always look for a win-win, and so it was just kind of an overall career. I guess I got a chance to do another leadership thing through the UCLA, and that was exciting times, and kind of reminded me of all the things that I should know. So always looking for ways to learn and educate yourself and do better. So, yeah.
What about you're working now as kind of on an interim basis for different agencies as CEO?
Yeah.
Are you seeing, out of curiosity, any changes in like the generational work ethic or work approach?
Yeah, that's a tough question, and the reason it's a tough question is what happened right after I retired was a word called COVID. Nobody knew anything about COVID until I retired, and all of a sudden now the whole world knows about COVID. And
is that because you retired?
Yeah, I'm pretty sure it's because I retired.
That's what I understood. Yeah,
but the whole world now has a different aspect on what work is, and I trying to recruit a 4-year accountant right now, and I get this call from somebody in Phoenix, and they said, "Well, yeah." I said, "Are you planning on moving?" "Oh, no. I thought it was a remote job." So they were going to remote in to do an accountant's position from Phoenix and never come to Olympia. And it's just like, well, frankly, that wouldn't been heard of when I retired, which is only 3 years ago.
Right.
So that's a huge, huge change, I think, that we're all going through. And frankly, I'm just learning it because I'm getting back into the work environment just because of a couple of interim things that happened. And this is post-COVID. I mean, well, COVID's still going on, of course. And so right now we're looking at it and saying, okay, we need to bring people back into the office because there's just not enough controls. I think that's what happened, is that everybody is working from outside, but we're not really controlling to see if they're doing their job. How many hours a week are those people actually working and doing and moving the organization forward? Or is it they go out for a cup of coffee from their work desk and they notice the dishes aren't done and the dog hasn't been walked, and they're doing all of that, and then they're coming back to work and they're not putting in the 8 hours a day? And I don't think we do a good job of controlling that. I don't think we do a good job of measuring that. And so that's one of the things I'm pushing for. And as you can imagine, hitting a lot of pushback saying, this has been my job now for 2 years. I haven't had to report. I haven't had to go in. Why do I need to do that? So It's a tough world right now.
Mm-hmm. So do you have any mentors that jump out or that you've, over the years?
Yeah, probably the first mentor I'd talk about was Donna Carvia. Donna Carvia was one of the original board members for Valley View Health Center. And she was a Democratic secretary elected into a very Republican community. And when Donna called a meeting, people showed up. Everybody showed up. She was a powerhouse. And she never wanted to be the board chair. She was she was the secretary, or she was the treasurer. She would do anything, but she didn't want to be the leader. But she was amazing at what she taught me politically. You get into these, somebody put something in the newspaper about Valley View, and it just pushed my button. So I wrote up this statement that I was going to send to the paper and say, that was a bunch of blah, 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 blah. And Donna would say, Steve, don't ever put in writing what you don't want everybody to see. You won't gain anything by doing this. And she was my mentor politically. That kept me out of trouble, because you can really start trying to get into this kind of match back and forth between the newspaper, and there's a no-win there. And so I learned from her a lot. Yeah, a lot. I always wanted to be, and always felt it was my job as a leader to make the people that worked for me better leaders. And so I tried to be a mentor to those that wanted to accept that leadership. And that was always important to me. There are some people, I know we just lost somebody, a lady by the name of Beryl Cochran. And I'll just share that Beryl was a scary individual and was introduced me. Oh, that's Beryl. She looked like she just walked out of the backwoods of Alaska. And again, this word connection came up. Beryl was a person that had the answers you go to. And so I introduced myself to Beryl because I needed some information. She came across very direct, but with information. And so I knew I could call her and always get an answer. So I reached out and called her a couple of times, and she always gave an answer. And then one day I met her at a meeting, and I had a dog tie on. And she started talking about her dogs and my dogs, and all of a sudden we connected. And from that moment on, Beryl's heart was just open. She was just an amazing person, and she had so much knowledge that she's so willing to share regardless of whether you're connected or not. So again, it's back to that piece that I learned a long time ago, is if you can connect with somebody, it just makes that communication flow so much nicer. Mm-hmm. So she was an amazing individual. Mm-hmm. And you're one of my mentors. Believe it or not. I mean, your knowledge of the FQHC world and everything that goes on financially is just mind-blowing. And you've helped so many different people. And so I want to be able to do that too. I want to be able to help people. And so I'll never measure up, but thank you for your leadership as well.
Well, you're welcome. Thank you. That wasn't actually a planned question for
I know,
answer.
But,
so.
Did you get all your planned questions done?
I have just a couple more. Strategic planning, is that an important aspect of a community health center? You talked about, you kind of found growth and then presented it and did your own work, figured out. Yeah. So has strategic planning been, it's a lot of community health centers do it. A lot of people say this is a 3 to 5 year plan. They put it together, and then in about a year, the whole thing's blown up because this industry is such a dynamic industry. Have you found it's a beneficial process?
I found it beneficial for my board to come up with this strategic plan that said that we want to provide services where the people live. We don't want them to come into some great big mega office. So I found that as a guiding light, a guiding principle. And that really never changed. We talked about it, but it didn't really change. But you're right. The feds want a strategic plan. You actually get written up if you don't have one. So you have to do one because you get a federal grant. But I've never been, if somebody wanted to help create a strategic plan, I wouldn't apply for that job because I've never gotten good at it, because exactly as you just said, things change so quickly. But I'll tell you the other thing that it's a difference in philosophy is a budget, right? Is you should have a budget and you should monitor the budget. But some of my colleagues as a CFO would not let somebody work overtime because they were at budget. And from my perspective, if that person's working overtime, you're not having to hire another person, and you just got 3 or 4 patients in the door and out the door because they worked 2 hours overtime. So we got to see more people. It didn't cost you that much more. And your staff is more satisfied because they're actually able to make a little bit more money. So I think budgets sometimes are put into this perspective of this is you shall not cross this threshold. And I think that's really wrong. I think there's good reasons to go over your budget in different areas. If it means more patient care, then you should be absolutely going over your budget. So just another thought.
Good. And I have one last question.
Okay.
You know, this industry is really for the purposes of serving those people who otherwise don't have access to health care. It's not a insurance, it's primary care for people who need access to health care. There's a lot of compassion in community health centers because of that mission. A lot of people who have put so much into this just because they want to help somebody. Do you have any specific human interest stories or examples of individuals who've been helped in community health centers that really spoke to you because of their need or their thankfulness or whatever the situation?
Yeah, I'm drawing a blank, Joel. Yeah. Give me an example in your world.
One example I have is when I was working in Coeur d'Alene, there was a guy that came in with a mole on his back to the emergency room. Didn't do much, said, don't worry about it. Didn't have, full mental capacity. Went home, lived in the Silver Valley. Came back to the clinic about a year and a half later, and his back was just absolutely, covered with cancer. And he ended up passing away. But the effort that the physicians and the staff put into trying to help that person and the heartache they felt just really was an emphasis to me around, this is why we're here. These are people who are making decisions every day around, and it's easy to discount it. That's that socioeconomic training I was talking about, where you don't understand what it's like to live in a economic class that's outside of where your comfort zone is. But if you step into that a while, there's a lot of pain and struggle. It gets to that connection that you're talking about. And those stories, I think, are real helpful for people to understand and connect. So I thought if you have one, it would be a good kind of an exclamation mark to our conversation.
I guess the thing that comes to mind, and I appreciate your story, is I went over to see an uncle that was wheelchair bound. Hadn't seen him in a long time, and he was in Ione, Washington. And I walked in to see him. He recognized me. Mentally he was fine. Physically he was falling apart. And on the top of his head he had this huge cancerous growth. I looked at it and I knew that something major was wrong. And I said, what's going on? I said to his son, what's going on with this? And he said, well, he doesn't really want to go to the doctor. The doctor really doesn't want to see him, and it's just really hard for him. And I said, well, let me make some phone calls. So I called, because I was still an executive director of Valley View, I called the executive director of the health center that was out of Ione. And I said, here's the situation. He doesn't have any money. He's got Medicare of some kind, I'm assuming, but he really needs to see a doctor. And she called the clinic and talked to the doctor, and the doctor said, absolutely, send him on up. So we're able to get my uncle into care, and the doctor spent 2.5 hours with him. And so I said, there's compassion in that doctor that was amazing, and for the executive director. And so I called the executive director, thank her, and she said, that blew my whole productivity for the day. But in the sense that didn't really matter. Both of us knew that didn't matter. What we're after is getting an individual care that they needed. And they spent 2.5 hours with my uncle, and he went back to see them on a regular basis until he passed away not long after that with cancer. So that was
it's a good story.
It was exciting that I was able to know who to call to get in the door. But I don't know that they wouldn't have got the same experience if they just showed up the door and showed them, because that's what FQHCs are about. Yeah, right. You're absolutely right. Thanks for asking.
All right. Good. Thank you, Steve.
Yeah.
Appreciate your time.